Hey everybody, welcome back to the ECG of the day. My name is Reid. And before we get started, don't forget that you can download the PDF of today's ECG document down in the description that is linked. And feel free to like this video and subscribe to the channel if you enjoy this content. So let's jump into this. So the first thing I like to do is look at the forest, and the trees of the forest are my QRS complexes. And so I kind of just maybe pick a lead, maybe lead 2, this rhythm strip here, and I see I've got this narrow complex rhythm that seems to be a bit regular. And then all of a sudden we have a change, and we have a change where we have this pause, and then we kind of have this series of a couple of irregularly spaced beats, right? The R to R interval between these two beats is a little bit different from the R to R in this long pause again, and then we kind of have a continuation of that pause. And so trying to figure out, why, what is the change, what is causing this arrhythmia? It is a narrow complex rhythm, and so that tells me that it's likely coming, at least the conduction of ventricular depolarization is occurring at least via this nice His-Purkinje highway system that allows for rapid depolarization throughout the ventricles. And so that makes me start wondering, well, what is happening at or above the AV node? And so I notice that there are P waves. If you look here, there are some P waves. And so let's figure out what we think is going on. So let's evaluate what the atria is doing in this rhythm. And so those P waves, I notice that they are negative in my inferior leads. So leads 2, 3, and AVF. Notice that my P waves, if I zoom in at these P waves, are negative. So that P wave is negative. This P wave in lead 3 is negative. In my P wave in AVF right here is negative. So the P waves that are contributing to this initial rhythm are negative in leads 2, 3, and AVF. That tells me that this is an ectopic atrial rhythm, right? Because depolarization throughout the atria is occurring from inferior to superior, and that would really only happen as if there was some atrial focus that was firing off and causing depolarization to occur in that fashion. So we've got an ectopic atrial rhythm that is occurring, in this first section of the ECG. It's occurring at a rate of 300, 150, 100, 75, so anywhere between 75 and 100. So I'm going to call this, maybe 85 beats per minute. And so that's kind of what we, so it's not an ectopic atrial tachycardia, it's ectopic atrial rhythm. And so let's continue on with this strip and see what's going on. We see we have a pause that is here. So this pause, if we zoom in on it, we wonder, well, what happened? Are there still ectopic atrial P waves that are occurring? And if I look through, I don't see any ectopic atrial P waves. I also don't see any more sinus P waves until I see another P wave, and that's negative in my inferior lead. So it's another ectopic P wave, and that P wave conducts to the QRS. And then this shorter pause that we said kind of occurs here. You can see we have a different morphology of our P wave, and that P wave is upright in leads 2. It's got that almost that biphasic pattern in V1. So I wonder if this could be a sinus P wave that conducts to the next QRS. And then when you notice, we look again, we see no P waves, no P waves, no P waves until we get another ectopic P wave. So we have a lot of ectopic P waves scattered throughout this rhythm. I would call this severe sinus node dysfunction, right? We're only having one sinus P wave here. We should be having more. So I would say this person definitely has some type of sinus node dysfunction. Why that's the case, right? It's hard to always tell. This is just one snapshot in time. But let's keep evaluating this rhythm. So we've got our AV node that we can measure with our PR interval. We see that our PR interval here, from the beginning of the P wave to the beginning of the QRS, it's on the lower side of normal, right? That PR is roughly 3 small boxes, so 120 milliseconds. And that's to be expected, right? Especially if we have a focus coming from low in the atria, it's not going to take much time to get to the AV node. So we might see a little, maybe it's just on the short side of that PR interval. But as we already noticed earlier, we don't see any P waves that are not conducted to QRS. So the AV node is working appropriately. Let's evaluate our QRS complex. Our QRS we said was narrow. And if we look at it, it's isoelectric in lead 1, so that means it's perpendicular to lead 1. It's positive in AVF. So if I draw a perpendicular line here in lead 1, so perpendicular to that would be up and down. And because it's positive in AVF, it tells me that my axis is going down straight towards AVF. So it's almost right axis. It's borderline right axis deviation, but not quite. And if we look through the precordium, you see I have this in V1. I've got this little r, deep S, and then an R prime, right? In V1, R, S, R prime. And so this is an R, S, R prime pattern, which tells me that we have late forces that are going towards V1, which are represented by the R prime. And that really occurs whenever there's a right bundle branch block. However, in this case, the QRS is narrow. The QRS, if you look at the QRS width, my QRS is less than 120 milliseconds. So we can't call this a complete right bundle branch block. We can call this an incomplete right bundle branch block. And so that just means that the right bundle branch is diseased, but not completely blocked. And so we're getting just some late forces that are not too much that's causing it to completely widen. And so the last thing we'll do, now that we've evaluated those things, is we can look at the QT interval. If you look maybe at this tachycardic portion, if I draw between two QRS complexes and I draw a line down the middle, you can see my T wave pretty much ends by that point, so I'm happy with my QT interval. Last thing we'll do is we'll look for pathological Q waves. We'll look for ST or T wave changes throughout. I don't see any pathological Q waves, which would represent a previous myocardial infarction. And the ST segments seem to be continuous with the normal baseline. We see obviously some T wave abnormalities on the same leads that are really capturing my right bundle branch block, which is typical. And so now that we put this all together, what do we get? What is the rhythm? What is happening in this conduction system? So we've got an ectopic atrial rhythm that initially was at a rate of 85 beats per minute, but then slows into an ectopic atrial bradycardia with intermittent sinus node beats. And so this person, what I would guess is they probably have a chronic, ectopic focus, right? There's some focus that's causing these ectopic P waves somewhere within the atria. They probably have a high burden of ectopic atrial tachycardia. And so what happens is, if you notice, when they have this ectopic rhythm, so when they have this ectopic focus that's depolarizing the atria, it also depolarizes the SA node. It also will zap the SA node, and if it does that enough times, that SA node will just become just over time overstimulated, and so then what can happen is it can fail to produce its own pacemaker potential. And so sometimes that's called a sick sinus syndrome. You see this also most commonly in people with AFib, but you can also see it in people with a flutter, and like we see here, an ectopic rhythm. So I hope this helps. If you guys have any questions, feel free to throw them down into the comments. Don't forget to subscribe to this channel and like this video. And I hope this helps you understand cardiac electrophysiology. So, alrighty, we'll see you on the next ECG. Take care.